Good morning, friends. I'm Molty Thomas, staff nurse working in DPRC. Today's our topic is tracheostomy care. Objectives, definition, parts of a tracheostomy tube, indications of tracheostomy, types of tracheostomy tube, purpose of tracheostomy care, tracheostomy kit, procedure of tracheostomy care, tracheostomy tube sectioning, tracheostomy humidification, tracheostomy tube cuff management, and references. Definition. What is a tracheostomy? A tracheostomy is an artificial surgically created airway functioned by making a hole in the anterior wall of the trachea and the insertion of a tracheostomy tube, which may or may not be permanent. So, ideal placement of tracheostomy tube is between the second and third tracheal rings, as you can see in this picture. Coming to the parts of a tracheostomy tube. So, in this picture, all the parts are clearly labeled. So we will see one by one. First one is main shaft or outer cannula. So this is the outer cannula. This one holds the tracheostomy tube open. The next one is neck plate or flank. This one. It stabilizes the tracheostomy tube, preventing it from migrating inward. It has holes on each side to allow attachment of ties to secure the trach in place. It has important information like manufacturer, model, size, everything will be written in this plan. Next one is inner cannula. So, this one fits inside the outer cannula to facilitate cleaning of the tracheostomy. And next we will see the obturator. This one is the obturator. It assists with the insertion of the tracheostomy tube. It provides a smooth surface to guide the tube during the insertion. Next, we will see the cuff and the pilot cuff. So this is the cuff and this is the pilot balloon. Cuff is an inflatable air reservoir. It helps to anchor the tracheostomy tube in place and provides maximum airway, sealing with the least amount of local compression. Air is injected to it for inflating the cuff. Pilot cuff. Pilot cuff serves as an indicator of the amount of air in the cuff. Coming to speaking valve, a tracheostomy speaking valve is a one-way valve that allows the patient to breathe in through the tracheostomy tube, but not out. Indications for tracheostomy tube. They are prolonged intubation, facilitation of ventilation support, inability of patient to manage secretions, upper airway obstructions, inability to intubate, adjunct to major head and neck surgery, adjunct to management of major head and neck trauma. Now we will see the types of tracheostomy tube. First is cuffed or uncuffed, fenestrated or non-fenestrated, disposable or non-disposable inner cannula, metal tracheostomy tubes. First one is cuffed tube. So in the cuffed tube, inflated cuff creates a seal between the trach and the trachea. Air cannot pass around the trach. Used to obtain a closed circuit for ventilation. Cuff must be deflated if using a speaking valve. In the cuffless tube, used for patients with the tracheal problems or who are ready for decannulation. It may be able to add a speaking valve to allow patient to talk. Next is fenestrated and non-fenestrated tube. So fenestration means it is a hole situated on the curve of the outer tube. See like this. This is a hole situated on the curve of the outer tube used to enhance airflow in and out of the trachea. So fenestrated tube can be cuffed or uncuffed. The shaft of the tube has an opening that allows air to pass the vocal cords for vocalization. It may cause increased granulation at the fenestration site and surgical decannulation may be required. So this is the example picture of fenestrated and non-fenestrated tube. Coming to tracheostomy care purposes. To maintain airway patency by removing mucus and encrusted secretions, to maintain cleanliness and prevent infection at the tracheostomy site, to facilitate healing and prevent skin excoriation around the tracheostomy incision, to promote comfort, to prevent displacement. So these are the purposes. First, we will see the tracheostomy kit. So this is the picture of contents that we used in our DPRC. A blocked or partially blocked tracheostomy tube may cause severe breathing difficulties, and this is a medical emergency. Immediate access to the tracheostomy kit for the individual patient is essential. A tracheostomy kit is to accompany the patient at all times, and this must be checked each shift by the nurse caring for the patient to ensure all equipment is available. We will see the contents of tracheostomy kit. First is brush, split gauze, 3 compartment tray, twill tape, dressing towel, gauze swab, cotton tip applicator, surgical gloves, plastic forceps, pipe cleaner. Other articles needed for tracheostomy care are hydrogen peroxide, normal saline, and tracheostomy 4. So now we will see the tracheostomy care procedure. First one is to assess the condition of stoma. We have to assess for redness, swelling, character of secretions, presence of purulence or bleeding. Presence of any of this indicates infection and culture examination may be warranted. Examine the neck for subcutaneous emphysema, evidenced by crepitus around the ostomy site. It indicates air leak into the subcutaneous tissue. Explain procedure to the patient and teach means of communication such as eye blinking or raising a finger to indicate pain or distress. This if we do like this, it obtain a cooperation from the patient. Wash hands thoroughly. It prevents cross infection. Assemble equipment. Open the sterile tracheostomy kit. Pour hydrogen peroxide and sterile normal saline in separate gallipots. Open other sterile supplies as needed, including sterile applicators, suction kit, and tracheostomy care kit. Put on face mask and eye shield. Hydrogen peroxide and saline removes mucus and crust, which promotes bacterial growth. It enhances performance phase of procedure, and it protects also the nurse. Do sterile gloves, place sterile towel on patient's chest. It maintains aseptic technique. Unlock the inner cannula and remove it by gently pulling it outwards you in the line with its curvature. Place the inner cannula in the bowl with the hydrogen peroxide suction. Hydrogen peroxide moistens and loosens dried secretions. Then remove the soiled tracheostomy dressing. Discard the dressing and gloves. Clean the flank of the tube using sterile applicators or gauze moistened with the hydrogen peroxide and then with the normal saline. Use each applicator once only. Using the applicator or gauze once only avoids contaminating a clean area with a soiled gauze. Clean the stoma tube with the gauze. Half-strength hydrogen peroxide may be used for this. Thoroughly rinse the cleaned area using gauze coils moistened with the sterile normal saline. Hydrogen peroxide helps loosen dry crusted secretions. Hydrogen peroxide is irritating to the skin and inhibits healing if not removed thoroughly. So make sure the hydrogen peroxide wiped off completely. Dry the stoma tube with the dry sterile gauze. An infected wound may be cleaned with the gauze saturated with an antiseptic solution, then dried. A thin layer of antibiotic ointment may be applied to the stoma with a cotton swab. It may help to clear the wound infection. Coming to the cleaning the inner cannula. First, to remove the inner cannula from the soaking solution, clean the lumen and entire cannula thoroughly using the brush in the tracheostomy kit. Rinse the cleaned cannula by rinsing it with sterile normal saline. Thoroughly rinsing is important to remove hydrogen peroxide from inner cannula. Remove solution adhering on the cannula. Replace the inner cannula and secure it in the place. Insert the inner cannula by grasping the outer cover. This secures the flank of the inner cannula to the outer cannula. Apply sterile dressing. Open and refold a 4x4 gauze dressing into a V shape and place under the flank on the tracheostomy tube. Do not cut gauze pieces. In our center, we are using tracheostomy 4. Ensure that the tracheostomy tube is securely supported with the applied dressing. Change the tracheostomy ties. Leave the soiled tape in place until the new one is applied. Grasp slit end of clean tape and pull it through opening on one side of the tracheostomy tube. Pull the other end of the tape securely thoroughly the slit end of the tracheostomy tube on the other side. Tie the tapes at the side to side of the neck in a square knot. Leaving tape in place ensures that tube will not be expelled if patient coughs or moves. This action provides a secure attachment with knot. It prevents irritation and aids in rotation of pressure site. Excessive tightness compresses jugular veins, so decrease blood circulation to the skin and results in discomfort for patient. So while tying this, while tying it should not be too much tight. Next, at last, we have to do the documentation. Document all relevant information in the chart, tracheostomy care carried out, dressing change, and observations. Next, we will see the tracheostomy tube suctioning. So, tracheal suctioning is a means of clearing the airway of secretions or mucus through the application of negative pressure via suction catheter. How to do a tracheostomy tube suction? First one, to connect the catheter to the suction machine. Do not touch the end of the catheter that will go into the tracheostomy tube. Second step is to insert the catheter the proper distance in the tracheostomy tube. Usually the length of the tracheostomy tube plus 1 by 4 inch. The third step is apply suction by putting your thumb over the hole in the catheter while you gently pull the catheter back out. Gently roll the catheter between your thumb and forefinger as you pull the catheter out. And while doing suction, the suction should be done PRN after chest PT and nebulization. The pressure setting for tracheal suctioning is 80 to 120 mmHg. To avoid tracheal damage, the suction pressure setting should not exceed 120 mmHg. This is very important. It is recommended that the episode of suctioning, including passing the catheter and suctioning the tracheostomy tube, is completed within 5 to 10 seconds. Next is tracheostomy humidification. A tracheostomy tube bypasses the upper airway and therefore it prevents normal humidification and filtration of inhaled air via the upper airway. Unless air inhaled via the tracheostomy tube is humidified, the epithelium of the trachea and bronchi will become dry, increasing the potential for tube blockage. So these are the two methods for tracheostomy humidification. First one is heated humidification. Devices which deliver gas at body temperature saturated with the water prevents the thickening of secretions. The temperature is set at 37 degrees centigrade, delivering a temperature ranging from 36.5 to 37.5 centigrade at the tracheostomy site. This is the picture for heater humidifiers. This one we are connected to the ventilators and all. This one. The next one is heat moisture exchangers, HME. It contains a hygroscopic paper surface that absorbs the moisture in expired air. Upon inspiration, the air passes over the hygroscopic paper surface and moistens and warms the air that passes into the airway. Now we will see the tracheostomy to cuff management. The cuff pressure should be maintained between 20 and 30 mmHg. Higher cuff pressure may compress tracheal capillaries, limit blood flow, and predispose the patient to tracheal necrosis. So it's very important to maintain the cuff pressure. A pressure manometer is a handheld device used to measure tracheostomy to cuff pressure. So this can be used for maintaining the cuff pressure. These are the references. Thank you.